not advancing for me. All right, so here's what I'm going to do. I'm going to kill that. No, I'm not.
So is there supposed to be 5 people in a booth for the project?
No, it's supposed to be 4, but we've got a bunch that signed up.
Okay, there's some spaces open.
So what's going on here?
Nobody wanted to know reproductive.
Did you know it? Let me see. Nobody wants to touch that.
Sorry. All right, so we're talking about the respiratory system. We talked about how the respiratory system is involved in our body's functioning. So we all knew that we had gas exchange. That was a biggie. We didn't actually realize the importance of the surface area for diffusion and osmosis, but now you're looking at diffusion and of gases back and forth, CO2 and oxygen. But now you can appreciate that because now you've seen what the lungs look like. And we've talked about the surface area of the alveoli and how we have so many alveoli, and each of those alveoli provides the surface area for the diffusion of gases between the circulatory system and the lung tissue itself. Of course, it's very important that we protect all those surfaces because, right, we want to keep it moist, we want to keep it safe, we don't want any foreigners getting into our circulatory system. So we want to keep it nice and clean. Temperature extremes want to limit the temperature variation because ideally things are working at about 98, 99 within our body. We looked this morning at the vocal folds, the vocal cords, same name, same structure, 2 different words, because that's how we generate our sound, our voice. We didn't really look closely at the olfactory epithelium, but some people had that half skull model out, and you might remember from 2002 about the bipolar neurons and how they delve down into the mucosa of your nasopharynx, and that is how we get our odorants into our nervous system. You didn't understand really anything about renin last term, except that it was produced by the produced by the kidney, and then from the kidney that renin goes to the liver and results in the conversion of angiotensinogen to angiotensin 1, and from angiotensin 1 we get conversion to angiotensin 2 in the lungs, and that's how the respiratory system is involved with our blood pressure control. That ACE, angiotensin converting enzyme, is one of the targets for blood pressure medication. So if somebody has hypertension, one of the more common drugs that they are using is called an ACE inhibitor. So an ACE inhibitor is going to inhibit the production of ACE, and therefore you're not going to convert angiotensin 1 to angiotensin 2, and you won't have that widespread vasoconstriction activity of angiotensin 2. And that's how we can tamp down hypertension or help somebody with hypertension. That's just one of the multiple hypertension drugs that are out there. We're going to talk more about the respiratory pump today, I believe. This morning while we were looking at the muscle man, we're talking about how our respiratory system is important for participating in defecation, urination, and birth. And that is because we need to compress the abdominal viscera, and we do that by holding our breath and pushing down on that abdominal viscera. Holding our breath. And then lastly, we have those little alveolar macrophages that help us eliminate these very small blood clots that we don't want to get into our brain. And this is where we stopped, right? This is where we stopped. We have some variations in terminology and structural organization in our respiratory system. So we have an anatomical arrangement and we have a functional arrangement. In terms of anatomical, we're looking at an upper respiratory system and a lower respiratory system. And maybe you've heard of it having an upper respiratory infection. If you have an upper respiratory infection, it means you have something going on in the head. You got a cold. That upper respiratory system is divided from the lower respiratory system by the larynx. Now, do some research. What is the definition of the upper respiratory system versus the lower respiratory system, and what's the dividing line? Well, you're going to come up with at least 3 different answers. And so, for our purposes, we are not going to worry about whether or not the larynx is in the upper respiratory or the lower respiratory. We're just going to know that the larynx serves as the dividing line between the upper respiratory and the lower respiratory. Believe it or not, in some circles, the difference between upper respiratory and lower respiratory is the dividing line between the epiglottis and the arytenoid cartilages. And for me, it's like, we don't need that. We're just going to know that the larynx separates the upper respiratory anatomically from the lower respiratory. The lower respiratory would be trachea and lungs. All we have to know about that. You will see, literally, in some places, lower respiratory includes the larynx. You'll see in other places, upper respiratory includes larynx. Yeah.
Is the larynx the line of demarcation for both? Because you ask, oh wait, yeah. So it's just the larynx.
Yeah, we're just going to use the larynx as our point of separation.
Okay.
Not any part of the larynx, and we're not including the larynx in the upper or the lower. It just separates the two. Okay. So that's our anatomical divisions. And then we have our functional divisions. And the functional divisions include what we call the conducting zone or division and the respiratory zone or division. And you can see here, as it says, that the conducting zone is all of those spaces and tubes that are carrying gases back and forth from the respiratory zone where we have the functional units, the alveoli, conducting diffusion of gases back and forth. So the conducting zone is going to include all of the structures that we see here, the nose, the nasal cavity, the nasopharynx, the oropharynx, the laryngopharynx, down the trachea, not the laryngopharynx because that's not actually part of the larynx, but from the larynx down through the trachea, down through the primary bronchi, the secondary bronchi, the tertiary bronchi, until we get to these respiratory bronchioles. And the respiratory bronchioles can have little alveoli pooching off of them. And so we are going to include the respiratory bronchioles, the alveolar ducts, and the alveoli themselves are included in the respiratory division or zone. So everything else, all the other structures are part of the conducting zone. Respiratory zone, where we have the actual action of movement of gases, diffusion back and forth, from the blood to the alveoli, from the alveoli into the blood. And you can see here, upper respiratory, lower respiratory tract, upper respiratory tract, lower respiratory tract. They don't even try and divide the larynx. But the notes do include, I think the larynx is included in the upper on the notes. But again, that's not something I'm concerned about. We know the larynx and how important the larynx is. Just not going to worry if it's called upper respiratory or something. Okay. So in the upper respiratory tract, we include the nose. Here's our nose. Remember that the nose has a bony structure and then a cartilaginous structure. The nasal septum. What kind of cartilage is that? Hyaline. Yeah, good. Hyaline cartilage. That hyaline cartilage and the bony septum between the two nasal bones are going to separate your two nasal cavities. Now the nose has two little holes that we are going to refer to as the nares or the nostrils. Nares or nostrils. Just inside the nares is the nasal vestibule, and there is where we have nose hairs. Nose hairs, the bane of some people's existence, especially as you get older. Those nose hairs, they show up more and more, especially in older men. Have you ever noticed? Old men with nose hairs? Yeah. So those nose hairs are really important. They protect the nasal cavity from bugs getting up inside the nasal cavity and through the nasal passageways. Fruit flies, gnats, little flies. Anything that wants to get up in there, it can't because we have those nice hairs. Just inside that vestibule, you have some keratinized, stratified squamous epithelium. I think you can appreciate the value of having that there because, I don't know, I've only met one person in all my years of teaching this that never picked his nose.
Yeah, but that's self-reported.
Good point, June. No, he was really adamant. I was like, oh, come on. You've never really? Really? So anyway, so yeah, sometimes you got stuff, you gotta get out of there. And it's good to have the keratinized stratified squamous protecting that. Just beyond that stratified keratinized squamous epithelium, you have pseudostratified ciliated columnar, and that goes all the way up to the top of your nasal cavity into your nasopharynx. So we're going to take air in through our nares, and we're going to roll that air over these conchae. You remember them from the skeletal system? Inside the nose, you identified the conchae. The conchae are covered with mucous membranes. Remember from breathing or your sensory structures and olfaction, how important those conchae are. Your superior, middle, and inferior conchae, covered with mucous membrane, serve as a great means for warming, moistening, and filtering the air that you breathe in through your nose. The turbulence that's created by those conchae and the meatuses, the little hollows, little valleys in between them, is further a means for filtering that air, moistening that air, and warming that air before it reaches your lungs. Remember, we have the vomer bone and the perpendicular plate of the ethmoid bone that are providing for that bony septum that is deeper from the highlighted cartilaginous septum. So here's a nice cross-section of the conchae. You can also refer to them as turbinates. That's how I learned them. They're called turbinates in dogs, cats, horses, cows, blah, blah, blah. We have just 3 sets of turbinate bones. And again, it's all about creating turbulence, hence the name turbinates. And that turbulence means that we can really comprehensively warm, moisten, and filter the air that we're breathing in. Hard palate, we looked at that this morning. Bone, soft palate beyond, muscle, mucous membrane, with a little uvula hanging off the bottom of that. What's the purpose of our hard palate?
Is it to protect the nasal cavity when we're chewing? Absolutely,
Preventing food from going up into your nose. Has anybody ever had milk or stuff come out your nose?
Yeah.
So my husband won't eat pasta. Did I tell you the story? My husband won't eat pasta because when he was a kid, he had, I swear he told me they were SpaghettiOs, but it was spaghetti. Out the nose. So he has not touched pasta ever since then.
He's got to reconcile his trauma.
He's only,
He's got to do some work with that.
Yeah, several decades later, he's still not gotten over it. All right, so we have the hard palate preventing food from getting up into the nasal cavity. What about the uvula? Does anybody know what the uvula is about? It has multiple functions. It's a good trigger for the gag reflex. That's a biggie. It's also important for keeping things moist, just like everything else of our mucous membranes. A 2, because it's still a part of the soft palate, prevents things from getting up in the nasal cavity. This is fascinating to me in immunological importance in that we have this mucosal intolerance of inhaled or ingested foreign proteins like pollen. And so it actually suppresses the immune response, the pollen does, but this gets it going, the uvula. Yeah. So we talked about all of that. This is all important stuff. Keeping that air moist, filtered, and moving. So our nasal mucosa, as we were just talking about, starts out in the nares, in the vestibule, as keratinized stratified squamous epithelium. And then we move on from there to pseudostratified ciliated columnar epithelium. And I want you all to remember, all those names are important. So as you're writing them down on a quiz, remember, use every word. Not just pseudocyte, columbar, because they're ciliated versus non-ciliated. So we want to include ciliated. Epithelium. There are goblet cells all along the way. In fact, we had a really nice slide this morning that had a lot of goblet cells. It was your slide, wasn't it?
Yeah, I took a picture of it.
Yeah, it was really nice. Lots of goblet cells. What are goblet cells? They are single-celled glands producing mucus. Lots of mucus in the respiratory system. That mucus, of course, is very important because it traps all of those foreign particles that we breathe in, because God knows this air is hardly clean. And we don't want that air with all those particles to get into the deepest recesses of our lungs. And you remember this? Our respiratory system is actually outside the body, because there's a straight track from the nose and the trachea down into the lungs from the outside. Same with our urinary system, our reproductive system. All exterior. Digestive system, the entire tube, external. Communicating with the world. So, we got cilia that are moving that mucus up and out. We talked about that this morning, the mucociliary escalator. It's part of the pharynx. It's also part of the trachea and down into the lungs. The surrounding the epithelium, we have a lamina propria, and within the lamina propria there are mucus glands, those seromucus glands. We also have within the lamina propria, this morning we saw this lovely little patch of lymphoid tissue, lymph nodule. Remember that from 232? So we have those surrounding in the lungs, very important. Plasma cells, blood vessels, all of this is contained within the lamina propria, surrounding our tubes that are bringing air in and out of the body. You got your olfactory epithelium, and we looked at that this morning on those models. Remember your olfactory epithelium with the bipolar neurons dipping down into the mucosa, picking up those odorants, converting them, called transduction. Remember all of that? Converting those odorants into a chemical that we then send to the brain, and the brain said, oh, I smell vanilla. Or, oh, I smell dog poop. Something like that. And so, what else do we have? Within the lamina propria of the inferior conchae, there is a collection of blood vessels, lymph veins, they refer to as the swell bodies. And they say that these swell bodies operate on opposite sides. And I want you all now just to close one nostril. Breathe in. Now, close the other nostril. Breathe in. Is one clearer than the other? Mm-hmm. So your swell bodies are a little swollen on that side. It's perfectly normal, because this means that the pressures are getting reset, preventing preventing drying. So yeah.
Is that why like people who sleep on their sides, sometimes like one nose you can't really like breathe out of,
breathe in and out.
The other one you can?
Yeah, so, and it might switch.
It does.
It does switch. So this says every 30 to 60 minutes. I've yet to have a class that remembers to check them at the end of class, but I would love it if we could all just remember to see if our swell bodies have switched sides before we leave and test this particular theory, because they're claiming this is fact. So we'll check that out. But also, Kesa, you can have damage to the septum. So my nose was broken when I was 4 or 5. Nobody knew it was broken because it was all cartilage then, nothing was set. But as I grew, so did my nose. And I had a crooked nose. And when I went to a plastic surgeon to talk about that crooked nose, he said, oh my God, you have a 90% blockage in one nostril and a 70% blockage in the other. And your septum doesn't do this, it does this. So I was 30 years old before I realized, no wonder you can't smell anything. And I still can't smell anything really. I smell.
So were they able to go in and try?
Oh, he had a beautiful nose. This is,
Oh, that's the new.
yeah, this is the new nose,
Okay.
but it's not so new. But worked great.
But did it affect your smell now? Like, did it make your smell better from the initial?
Didn't really, no, not so much. Yeah, I don't have the best smeller. It's not good for somebody who works in the wine industry, but I fake it. All right, so we're gonna check out our swell bodies in a moment, see if they actually are opening up for us from the side. We have sinuses that are participating with our respiratory system. These sinuses have several functions, as you can see, and we looked at those sinuses, and you did some of the sinuses in 231, but we got a little more depth here. We have our frontal sinuses, we have our maxillary sinuses. These are the two we're really familiar with. You get a cold, your frontal sinus fills up and you want to rip the front of your face off. Same with the maxillary sinuses, you just want to like, horrible. That's because they're filled up with fluid and the mucosa swells. That's where the pressure comes from, your sinus pressure. But we also have these cells in the ethmoid bone and the sphenoid sinus behind the ethmoid bone. Remember the floor of the cranial cavity with the ethmoid bone where your cristagalli is and your olfactory bulbs sit in there. And then just behind that, the sphenoid bone where so many nerves pass through, large wings, and right? Remember all that? So we have these sinuses. They serve, as it says, as a means for resonance, so it impacts how your voice sounds. When you have a cold, you don't sound the same as you did when it's clear. They tend to provide a little bit of lightening of the load, because it's a fairly heavy structure. So the sinuses give a little bit of lightening of the load. They participate, as it says, in the moistening and the warming of that air that we're breathing in, breathing out. And we cool air as we breathe it out, by the way. We actually cool air in expiration. And then also, production of mucus, right? And so that production of mucus is what we feel the buildup of when we have a cold and we produce extra mucus. Why do we produce extra mucus? Because we have foreign proteins that are impacting our respiratory system. And lastly, and I think this is the coolest part of all about sinuses, is they serve as a crumple zone. So if you have full frontal impact, your sinuses are going to prevent any impact to the brain. Isn't that brilliant? Brilliant. Yeah.
Not so brilliant when you're recovering, but.
Yeah, well,
So
better
it
that than
lessens-
your brain.
It just lessens the impact?
It reduces the potential for impact of your brain.
It's like a car.
Imagine, yeah, having a car accident and you're thrown forward and you hit
Our
the front.
sinuses are the bumper.
Yeah,
Oh, okay.
yeah.
Above.
So it would hit the sinuses before it would attack our brain?
Yep,
Okay.
your crumple
They
zone, right?
crumple, so
They would crumple so nothing else
brain
happens.
doesn't.
Exactly. Same thing with our, remember, we have cranial brain bone, and they have the diploe between the two layers of compact bone, which is another crumple zone.
Do the sinuses recover if this happens?
I guess it
Yeah.
depends.
I guess it would
on
depend on how
the
severe the
impact,
crumpling
right?
was, right? And how much damage is done, whether they can go in and rearrange
That
those.
makes sense.
Yeah. All right, so the next thing to talk about is the pharynx. So from the nasal cavity, here, there's our nasal septum. From our nasal cavity, we have a region known as the nasopharynx. Nasopharynx leads to oropharynx. Oropharynx leads to laryngopharynx. This nasopharynx is surrounding a structure that we learned in 232, has to do with hearing, auditory canal, also known as the eustachian tube and the pharyngotympanic tube. I call it eustachian because that's what I learned it as. My physician called it. Eustachian tube right here, nasopharynx. So remember, you get a cold, you can get a middle ear infection from that cold. Or you can get a swelling up of the eustachian tube so you don't hear as well because the mucosa is all swollen in that region. The nasopharynx is pseudostratified ciliated columnar. The oropharynx then is in the region of the oral cavity, and we call it the oropharynx, but mostly you refer to as your throat. So when you open your mouth and you look back at the back of your, somebody says, say ah, you lift your soft palate so that the throat is more visible. Oropharynx. What's the epithelium here, do you think?
Non-keratinized stratified squamous.
What did I hear?
Non-keratinized stratified squamous.
Right. Why is it non-keratinized stratified squamous?
So it's maintained like a moist and wet environment.
Moist and wet environment, plus all that food that you take in through your mouth, you're mixing up with some saliva, but it's by no means soft. And so we want to have a protective epithelium in this region. Then we come to our laryngopharynx. What do you think of our epithelium down here? Same, it's the same, because this laryngopharynx is leading to the esophagus. Here's our larynx, this is the esophagus.
And the laryngopharynx.
Laryngopharynx,
Laryngopharynx
Uh-huh.
is where it could also be cuboidal, right? Or is that a different?
No, I wouldn't think any cuboidal here. You
Okay.
might have some different epithelium on the epiglottis, but even that I think is non-keratinized squamous epithelium. Stratified squamous epithelium. I don't think there's any cuboidal there.
I was just trying to remember in histology you said something could be cuboidal too, so.
Oh, we're talking about respiratory bronchitis.
Oh, okay.
Way down the line. All right, what else do we got here? So, yeah, this is where we mix air, food, air and food, air down here, food down there. Ideally. Ideally. This is pointing out not just the pharynx and the region of the pharynx, but also the tonsils. So you remember your pharyngeal tonsil up high. We also have lingual tonsil, and we have palatal tonsil. And this isn't showing us our palatal tonsil, but it would be in this region right here. This is showing you the tubal tonsil. And this is a relatively new finding, believe it or not. And they call it the tubal tonsil because it's next to the auditory tube. This is also showing you the range of nasopharynx, oropharynx, and laryngopharynx. It's pointing out our hyoid bone. The hyoid bone, you might remember, is non-articular. It doesn't articulate with anything else in the body. But what it does do is a very important anchor for the tongue and the laryngeal cartilages, as we saw in lab this morning. So the hyoid bone is an integral part of the digestive system and the respiratory system because of the way it anchors those very important structures. So we took a little bypass from our anatomical structures to look at our histology. And we looked at this image in histologyguide.com. This is essentially the same image, and it is showing you the cilia and the cell bodies of those pseudostratified cilia and columnar and goblet cells, and then we also have those microvilli on the surface of those cells as well. These mucous membranes with the cilia, that pseudostratified cilia and columnar, are very important for capturing all of that debris in the air and moving it up and out because we don't want it to get down into the alveolus. The alveolus isn't really clean. But remember, from the nose and the throat, it's a straight shot from the exterior. So it's actually exterior all the way down to the alveoli. So that we have to keep it super clean. So we do that by producing lots of mucus and using that mucus to trap the particles and using the cilia to move that mucus up and out. That's why every once in a while you gotta cough up a chunk of mucus. You might swallow it, or you might spit it out, or you might blow it out your nose. Do you generally blow your nose? I blow my nose several times a day, right? Get a little, depends on whether you're sick, but even when you're healthy, sometimes you just gotta get rid of some stuff in your nose. All right, so we have pseudostratified cilia columnar in the nasal cavity, in the nasopharynx, and then again down in the trachea.
So wait, then our booger is just dried versions of
Dried versions of mucus and dirt, yeah. And if you're like me, I'm with horses, and mud season, curry, and there's lots of dust, I'm breathing that in. I go home, I blow my nose, and there's lots of brown stuff on the tissue. So it's working for us, right? All this is preventing things from getting into the deep recesses of our respiratory system. So we got the goblet cells that are making mucus, we got our seromucus glands that are laying in the lamina propria, and all of those mucousy producing structures in the cilia keep it moving up and out via the mucociliary escalator. And the rate of our production, we just talked about this, and the more you're exposed to this material, the more mucus you're gonna be producing because your body is responding to those particles. And then sometimes you get a virus, and the virus stimulates the more increased production of mucus as well, because it's all part of that prevention of pathogens from getting into the deeper recesses. Yeah. And then we have way down in the alveoli, we have these alveolar macrophages, or dust cells. I love the name dust cells because it depicts exactly what they're about. Anything that gets beyond that mucociliary escalator and down into the alveoli has to deal with alveolar macrophages. And they're gonna keep that stuff from getting into the circulatory system. So they're macrophages, meaning they phage, they eat things, they engulf things. And so, what do we have? So in the very upper reaches, right, our upper respiratory system is predominantly pseudostratified ciliated columnar, lots of mucus production. And we move down in through the trachea, we still have pseudostratified ciliated columnar. We get into the respiratory bronchioles, well, terminal bronchioles, let's say. We have columnar epithelium. There may be some cilia. We may have a reduction of the cilia, but we still have a lot of production of mucus. Then we go to our low columnar, and from low columnar to cuboidal. And these cuboidal epithelium you would see in the respiratory bronchioles. So this morning I was looking at some slides and we saw some really great examples of bronchioles, whether they were terminal, to be determined. Right? We're not going to worry about that so much as we are going to be able to differentiate bronchi from bronchioles. Cartilage, no cartilage. And the bronchioles are going to be going from simple columnar to cuboidal. And from these respiratory bronchioles, we go to the alveoli where we have simple squamous epithelium. By the way, do you notice what's not present anymore? No more mucus, which is good. Because only if you have pneumonia are you then going to see a buildup of fluids and mucus in the alveoli. And that's dangerous. Why?
Gas exchange.
No gas exchange. Very difficult gas exchange. Yeah, and you are fighting to breathe. Has anybody here ever had pneumonia? Were you sicker than ever before? Right? Sicker than ever before?
Me and my brother both got it, so we had to end up sharing a nebulizer.
Oof. I was so sick. I've never been so sick. The only thing was it dropped my blood pressure down to where it was supposed to be. Oh my gosh. It took a lot out of me. I was down to like 120 pounds and whew, sick. You get really sick.
I remember not being able to lay flat for like a month. Because I was
Yeah.
coughing.
Yeah, coughing. Oh, the coughing.
Oh.
It was
It's weird 'cause you don't
exhausting.
really have any other symptoms. Like I just got over recovering from
Yeah,
pneumonia,
yeah,
but I only reason why I went to the doctor was because I was like, I had this really bad cough, can't breathe, chest is tight, but I had no other symptoms. So I was like,
You had walking pneumonia.
what could possibly going on?
Were you put on?
Yeah, like
what is it called?
Antibiotics and steroids.
Yeah, big.
And,
There's a serious. I think it's Zymectrin or something. Does anybody remember what the antibiotic is?
that's
Were you going to say something, Kyla?
How
Kayla?
long is pneumonia last? How long do you have it for?
Well, it kind of depends on whether you identify it and how you treat it and how much of your lung is involved.
Oh, okay.
But I had the cough for the longest time and that sinus pressure for the longest time. It was finally, she put me on Sudafed finally. And prednisolone. Oh my God,
yeah, that's what I
prednisolone.
had prednisone.
Great stuff. Yeah.
So can pneumonia and like the excess mucus and less gas exchange lead to death of part of the lung?
Lead to what?
Death to like part of the lung?
I don't know if you get necrosis that way. I don't
I
know.
don't that's necrosis.
You'd still need to, you'd have to reduce the blood supply, and I don't think the blood supply is
Yeah,
reduced.
because I don't remember, my dad had pneumonia when he had COVID and part of his lung. I don't remember if he had like a blood clot or if it was just a pneumonia, but he had to have part of his lung removed because of
Oh,
that.
it might have been a clot.
Yeah.
That would be more drive for taking that, because you don't want that clot to embolize and travel through the circulation, go to the brain. Pulmonary embolism. Yeah. All right, and remember that we have that non-keratinized stratified squamous in certain portions of the pharynx. And we also have the keratinized here. Next to talk about is the larynx. Very important structure, the larynx, as you probably figured out, because it's the gateway directly to the lungs. It's the gateway into the lungs. The larynx is comprised of multiple cartilages. Some are paired, some are individual. These cartilages, for the most part, are made of hyaline cartilage. There is one of the cartilages in the larynx that is not, and I will tell you, it's the epiglottis. Now you tell me, what kind of cartilage is that?
Elastic.
It's elastic cartilage, right? You got elastic in two places, epiglottis is one of them. So the epiglottis is very important because it prevents food from getting into the larynx, down the glottis, while you're swallowing, usually. Every once in a while you might inhale a little saliva, which got past the epiglottis, and you have a coughing fit. Or you might inhale a bit of food, which you really don't want to do, and just have a coughing fit. It's because you have irritant receptors in the larynx that respond to that foreign particle getting in the wrong place. So we have the larynx is responsible for opening and allowing air in down the trachea and allowing air out from the trachea. It also is holding the vocal cords, and we generate our phonation, our sound, via the vocal cords, which are part of the larynx. And as this says, it's important for directing food down the esophagus and not into the larynx itself. So that's what the larynx is all about. We have 9 cartilages, as you can see here. Some of them are paired and some of them are not. Who can tell me which of the cartilages is unpaired?
Epiglottis.
The bottom one. What's it called? The cricoid. Cricoid, cricoid, tomato, cricoid. Yes, the cricoid is unpaired. We have another unpaired one. What's that? Thyroid. The thyroid cartilage, the one that we refer to as the Adam's apple. Right? Males have a more prominent laryngeal prominence, also known as the Adam's apple. The thyroid cartilage is prevalent in males because of that prominence, and that ridge is on everybody's, but more prevalent in males than females. So thyroid cartilage is unpaired, and notice that the thyroid cartilage doesn't even reach all the way around. It is horseshoe shaped, just one half of the ring. The cricoid, on the other hand, is a continuous ring, and it's actually more substantial on the posterior aspect than it is the anterior aspect. Then we have some paired cartilages. Oh, another unpaired cartilage. Which one is that? One more. Begins with an E.
The epiglottis.
The epiglottis.
Yeah.
Epiglottis is unpaired. And then we have the paired cartilages, and the paired cartilages include the arytenoid and the corniculate and the cuneiform. And these guys are all embedded in the mucous membrane that is surrounding and covering the inner surface of the larynx. Okay. Those are important because that's how we move the glottis and we move the vocal folds so that we can generate sound. This is the anterior aspect of the larynx. Notice that we have a membrane, the thyrohyoid membrane, connecting the hyoid bone to the thyroid cartilage. We have another membrane here called the cricothyroid ligament underneath the cricothyroid muscle. We have the cricotracheal ligament between the cricoid and the first tracheal ring. On the back side, there's our cricoid cartilage, thyroid cartilage, epiglottis, cuneiform, corniculate, and arytenoid. And then we have the cartilaginous rings. Remember, these tracheal rings are C-shaped. So they're incomplete rings. On the posterior aspect, they are bound to each other by a ligament called the annular ligament. This is the annular ligament. deep to the annular ligament is that trachealis muscle, the one that we use to reduce the diaphragm or the diameter of the lumen or relax it to increase the diameter of the lumen. So that's all of the structures of the larynx. We had a big discussion this morning about the vestibular folds versus the vocal folds, and it can be really confusing. We're going to just make it really simple for you. We're going to call the vocal folds, vocal cords, these fibers that we use to vibrate, to generate sound. We use the vestibular folds, or the vestibular membranes, to open and close the glottis. That's the hole that is created when we open up the larynx and allow gases into and out of the trachea. Let's look at them this way. So we have here our vocal cords are closed, close together. The glottis is closed here. This is our cricoid cartilage. There's our thyroid cartilage. Here's our arytenoids. There's the cuneiform, or cuniculate, excuse me, and then the cuneiform are being depicted here because they're sort of embedded in the mucous membrane. When we close these vocal ligaments, vocal folds, no air is moving in and out. When we open them, we can move air in and out. Here they are adducted, here they are abducted. Here we have our epiglottis, we have our corniculate cartilage attached to the arytenoid cartilage. There's a corniculate attached to the arytenoids. Here's our cuneiform cartilage. Now this is called the rhimaglottis. I just refer to it as the glottis because I learned it as the whole. That's the glottis. You can think of the vocal cords as forming the rim of the glottis. So the glottis is the whole. Here you can see the glottis, that's the whole. And they bound by the vocal folds or vocal cords. And see this vestibular fold right here? This is actually helping to open and close the glottis. Because the vocal folds don't have anything to do with the opening and closing. They are all about vibration. Maybe you'll be in a surgery and you'll be participating in intubation, surgery prep. You'll be participating in intubation of a patient. Intubation means that you're going to put a tube down into the trachea so you can direct gas, specifically how much gas and where that gas goes, right down through the trachea. Questions on that? So we're going to I like this image right here because the vestibular fold sort of shows you how it is lateral to, a little bit raised, but connected to these vocal folds, these vocal cords. So here's the quiz question. You're asked to identify this particular structure, but it's not the cord itself. It's just off to the side of the cord. What are you going to call it?
Vestibular fold.
Right. And then if you're asked what the function is, controlling the glottis. Yeah, good. All right, down to the trachea. So we covered our larynx, thyroid cartilage, cricoid cartilage, there's the cricothyroid ligament, and then we have our trachea. And the trachea is literally a tube. It is a conducting zone passageway. Its primary function is to move air in and out. But remember, it's also lined with pseudostratified ciliated columnar, mucus production, cilia, moving stuff up and out. So the function is to keep that moist air moving and keep the mucus moving out and the air moving in, moving out. Right. We have on the anterior aspect the cartilage, but on the posterior aspect we have that annular ligament. Remember me showing you? So used to having that. that annular ligament on the back side. So posterior is the annular ligament, anterior, see our cartilaginous rings, and there's ligaments holding each of those cartilaginous rings together as well. Pseudostratified ciliated columnar lining these guys, and we come down to what we call the bifurcation of the trachea to two primary bronchi. Bronchus is individual, so we have a right bronchus and a left bronchus, primary bronchi. The bifurcation has an interesting little structure that we use as a landmark. This is why, remember earlier I said it looks like a bikini bottom? So not all the models show it that way, but that's the way I think of it. So this carina is actually, they call it as an external anatomical structure, but actually the carina is inside the trachea. And the carina is loaded with irritant receptors. And those irritant receptors respond to any little foreign something that has made it all the way through the larynx, down the trachea to the carina. And that generates cough. So you can have a really deep cough. That's coming from your carina. You can have laryngeal coughing too, like when you have a laryngeal spasm, or in my case, in the morning I have mucus that starts to drain from my sinuses and it gives me a cough. I take some Mucinex, and then boom, I'm good for the rest of the day. By the way, that's a postmenopausal. I hate to tell you. It's just another one of those things. Yeah. So the carina is rich with those irritant receptors, and that's where your cough reflex comes from. Then the carina leads to your two primary bronchi. You have a right primary bronchi and a left primary bronchi. And those primary bronchi branch into lobar bronchi. Lobar bronchi. How many lobes on the right lung? Three. How many lobes on the left lung? Two. And that corresponds to our 1, 2, 3. 1, 2. Left, right.
These are secondary.
Notice that all the way down, all those bronchi have cartilaginous structures on them. Not all of them are rings though. So we start out with rings in the trachea, and then as we move down through the lobar bronchi and the segmental bronchi, the cartilage becomes known as plates. So they're not really little rings that go around. You have a plate here and a plate over here. And so they just are scattered along the length of those bronchuses. But the definition, right? Bronchus, cartilage, bronchial, no cartilage. If we took a cross section of the trachea, we see it. We have a cartilaginous ring. What kind of cartilage is it?
Hyaline.
That's right. And what's our lining? What epithelium?
Pseudo-stratified ciliated.
Correct. And we have here on the posterior aspect that trachealis muscle that binds the two ends of the cartilage along with those annular ligaments. They also bind the two ends. And this trachealis muscle is one that we can use to increase the diameter of our trachea should we need to increase our air exchange.
And the esophagus is posterior.
Yeah, esophagus is posterior. Yep. Mm-hmm. So this is kind of interesting. So we have this nice trachea, one tube coming all the way down, and our carina. So we have our bifurcation of the trachea here from to our right and left bronchi. You might notice that the right bronchus has a wider diameter than the left bronchus, and it's a little bit straighter. There's a bit more of an angle from the left coming off of the primary trachea, a little bit straighter route. So maybe you've heard of kids that like to inhale raisins and oh my God, stones, right? Kids do weird things. When they do, if it makes it past the larynx, it can lodge here because it's a straighter shot than the left. So your primary bronchus tends to be the one where objects get lodged. Mostly kids, right? Marbles, tiny little thing. Who knows? What's in the mind? Calvins. It would be Calvin that would do that. You know who Calvin is?
Yes.
Poor little Calvin. So cute. All right, so this and this enter into each lung, so right lung and the left lung. We have to get those bronchi into the lungs. Where they enter into the lungs is referred to as the hilus, or hilum, or hilum. Care how you call it? As long as you can spell it, you know what it is. All the blood vessels, primary arteries going in, primary veins going out, nerve innervation, lymphatics, all pass through that same region. Each lung has its little spot where all the vessels and that primary bronchus enters into the lung. Oh, and that's the end of that one.